Okay, welcome. My name is Carolyn Owen. I'm a CLL treater in Calgary. I am presenting the review of highlights from ASH on relevant presentations in the treatment of CLL. This is from ASH 2021. These are my disclosures, and there was some support for this project from AstraZeneca. The main questions that have been addressed this year at ASH really relate to updates on fixed duration treatment options and whether this is a valid option in younger fit patients, because most of the fixed duration therapies, VO or an IV to date, are in older patients, whether the benefits of venetoclax or BTK inhibitors also extend to patients with mutated IgHV, about how we use MRD in our treatment decision-making, and the difference between different BTK inhibitors and whether there should be a preference. So this is just a quick update to remind you of the status of approval for BTK inhibitors and BCL2 inhibitors in Canada today, with ibrutinib and acalabrutinib, both Health Canada approved, and probably zanubrutinib soon to be for CLL, but currently zanubrutinib doesn't actually have a CLL indication in Canada. So we wish to summarize the clinical trials that were presented at ASH this year in relevance to CLL and with Canadian treatment or implications. So these are the studies that were included in this report. Sequoia, which is zanubrutinib studies, of which there are several arms, but the two that are of interest are the frontline non-17p deleted comparison of zanubrutinib versus BR. And then in the arm D, which was a combination of zanubrutinib and venetoclax in previously untreated CLL. And then a couple other interesting studies. The FLAIR study is the large UK frontline study. There's a matching adjusted indirect comparison study, which is maybe not the best quality data, but if we can review that and see how interesting it is. A very MRD-directed update on GLOW, as well as the CLL13 frontline German study called GAIA, and then some updated data from relapsed refractory studies of the ELEVATE-RR and the ASCEND study. So for frontline CLL, the Sequoia studies, as I mentioned, examined zanubrutinib, which is a second-generation BTK inhibitor. Most of us in Canada know acalabrutinib as the second-generation BTK inhibitor, and this is similar with a more narrow spectrum of tyrosine kinase focus. This study is very similar to the Alliance study that many Canadian centers participated in that compared ibrutinib and ibrutinib rituximab to BR. So it's a similar population of patients who are 65 years of age or older and previously untreated, and it compares zanubrutinib against BR. The PFS strongly supports zanubrutinib, which is not unexpected, a continuous indefinite therapy that is highly effective versus a 6-month chemoimmunotherapy. This is really a similar looking curve to the Alliance curve. I don't think there's much else to say about it other than that the goal of the second generation BTK inhibitors is hopefully to have slightly less toxicity than ibrutinib. These are the AEs of interest, where interestingly neutropenia is slightly more common with zanubrutinib than I think we expect with BTK inhibitors, but atrial fibrillation seems much less than what we've seen with ibrutinib. Bleeding, I'm not sure. I think it's fairly comparable, I think, to ibrutinib. Hypertension, bit less, but still a reported AE. And then infections really are the #1 problem for all CLL patients receiving BTK inhibitors. This is the data from the cohort 2, which was the patients who have, I think, 17p deletion, and they didn't get randomized. They all received zanubrutinib, and it just shows you how effective BTK inhibitors are for that class of patients. So really all you can say here is that zanubrutinib looks similar to ibrutinib in terms of being better for prolonging PFS compared to time-limited BR, no overall survival advantage at this point, which is the same as the other studies have shown. We know that BTK inhibitor class works well in our high-risk patients like unmutated IGHV and deletions 11q. The combination zanubrutinib venetoclax data is very early, and I don't think there's much to say about this. Again, it's a non-comparative study. This was just, as you can see from this, a sort of extra cohort with deletion 17p. Given this combination, the patients started with zanubrutinib before adding the venetoclax, similar to the way they've done it with I plus V, and that works well to reduce lymph node burden. And so most patients are not high risk by the time they start venetoclax. Actually, nobody was in the study. The response rates are very good. These are two highly effective therapies. That's not surprising. The AEs of interest are similar to the AEs known for each of the two drugs. So neutropenia becomes even more common when you put both venetoclax and zanubrutinib together, but they didn't see any important new toxicities when they combined the two agents. And so I don't think you can take much more from this except to say that it looks safe to put zanubrutinib and venetoclax together. But this is, as mentioned, a non-comparative study. It's very early data. This study was interesting. This is a report of a matched adjusted indirect comparison of acalabrutinib monotherapy versus acalabrutinib with obinutuzumab, and comparing against other standard treatment options, ibrutinib monotherapy or venetoclax and obinutuzumab, because all of these studies are well-performed randomized clinical trials that have similar comparative arm. So the Alliance study compared against BR, the Elevate-TN study compared against chlorambucil O, the venetoclax and obinutuzumab or CLL14 study compared against chlorambucil O. Based on this, they can kind of do some pulling out of the patients and trying to choose patients that are sort of similar and indirectly compare them. This is a very obviously statistically complicated process, not as good as a well-performed phase 3 randomized clinical trial, but it's, I think, probably the best you can get right now. And I think what's interesting here is that when you look at PFS and OS for acalabrutinib and ibrutinib, they look very, very similar. The curves are completely overlapping. What the authors here found, I think they were trying to show us, is that it looks like the addition of the obinutuzumab may be improving outcomes, at least in terms of PFS. In this case, also OS against ibrutinib. We know that in the Elevate-TN study, they didn't power the study to be able to confidently assess a statistical difference between acala mono and acala plus obin. But most of us would like to not have to use obinutuzumab if we don't have to, because that adds cost and toxicity to BTK inhibitor treatment. This is the comparison against Ven-O, which is obviously time-limited therapy, so quite appealing in that regard. And again, it looks like the PFS and the OS are very similar for indefinite acalabrutinib versus time-limited Ven-O. But when you combine acalabrutinib with obinutuzumab, they're showing that it looks like the outcomes are a bit better. I'm not really sure what to make of this aside from, they also compare some side effects. And so we know the side effects of ibrutinib, and they had more AFib and hypertension with ibrutinib compared to acala and acala-O. And with Ven-O, we know that there's problems with infusion-related reactions and neutropenia. They said that there was less of those problems with the acala and the acala-O. But as I said, I don't really know much what to make of this data. It is not a phase 3 randomized clinical trial. And as I mentioned, although the addition of the obinutuzumab might improve outcomes for a small group of patients, I think it'd be useful to know who those are, because the majority of patients do really well with acala mono, and giving obinutuzumab with the BTK inhibitor will add a lot of cost. That's a lot of awkwardness with the patients having to come in for these long infusions, especially with the dose ramp up of the sort of loading doses of the obinutuzumab at the beginning. And currently with COVID still a problem, people want to try to avoid monoclonal antibodies if they can. So I don't really know that this is hugely clinically applicable today. The FLAIR study, I think, was the most interesting study presented at ASH this year for CLL. This is a large randomized clinical trial comparing FCR to ibrutinib plus rituximab. The time the study started, the Alliance data and the MD Anderson study that showed that rituximab really didn't add anything to ibrutinib were not yet published. So I think we should look at this and think of it like it's ibrutinib versus FCR. The patients had to be fit for FCR, but their upper age limit actually was 75. But most of the patients were not 75. The median age was 62, which is very similar to the median age in the CLL-8 clinical trial. So these are the patients, I think, that most of us were probably treating with FCR historically and still in Canada now. The progression-free survival, again, clearly favors ibrutinib, so indefinite chronic suppressive therapy with an effective agent like a BTK inhibitor will lead to longer progression-free survival than time-limited FCR for 6 months. However, there was no difference in overall survival between the treatment arms. They did not provide curves specific to mutational status, but somebody asked, and I think that there probably isn't a statistically significant difference even in overall survival amongst the unmutated patients today. So obviously the question is, why did the ECOG 1912 study show an overall survival advantage for IR over FCR and this study didn't? This study is significantly larger. It does include a slightly older age group. I think the median age in the ECOG 1912 study was something like 57 or 58. And the difference of 4 years in median age is actually quite a lot for a study. So the patients were much younger in the American study, and there were less of them. And that study wasn't powered for overall survival like this one was. Also, what is interesting is the overall survival with FCR in the FLAIR study is quite a bit higher than the overall survival of FCR in prior UK FCR studies, which just goes to show that with time, our supportive care is better, our selection to avoid patients with deletion 17p or to switch to more effective second-line therapies has led to much better outcomes. So the major thing that they presented was that most of the patients who progressed after FCR got a novel agent second-line, and that is our standard of care in Canada. So I think we can look at these data and say this is true for the Canadian population, that that getting FCR frontline at this point in time doesn't look like it leads to a loss of survival for deferring the novel agents to second line. I'm not saying we should suddenly start doing that even for the unmutated patients, but we should feel comfortable providing chemoimmunotherapy frontline for fit patients who can receive it, because this study clearly supports that. The serious AEs and deaths were interesting. There were more deaths from non-heme second cancers in the ibrutinib arm than in the FCR arm. There was more deaths and more events of myeloid second cancers in the FCR arm. And then there was more cardiac deaths in the ibrutinib arm. So this is obviously a known drug effect with ibrutinib. So the authors conclude that ibrutinib and rituximab is superior in terms of progression-free survival, but the fact that there is no difference in overall survival is because deferring these more effective novel targeted agents to second line does not seem to lead to a loss of overall survival. The GLOW data wasn't really particularly new compared to what was presented in the summer, but the focus was on MRD outcomes. So as a reminder, this is a study of ibrutinib plus venetoclax for fixed duration of about a year compared to chlorambucil obinutuzumab, and it was for older or unfit patients. The IV obviously did much better than the chlorambucil O in terms of progression-free survival. And in this study, they're just dividing out the progression-free survival outcomes by MRD so that you can see that if you have an undetectable MRD, you have a better progression-free survival in with IV and with chlorambucil O. This is something I think that we would have expected, but obviously we didn't have MRD data for IV before now. What is really quite interesting is that most of the patients who achieved undetectable MRD by our current definition of less than 10 to the -4 for IV actually were even deeper than MRD than that, and they also had MRD undetectability at 10 to the -5. This was less true for the chlorambucil O group, where a lot of patients still achieve undetectable MRD, but few of them were at the 10 to the -5 level. So although MRD undetectability can be achieved with chlorambucil O, it's actually not as deep a remission as with the IV. And so that leads us to believe that with time, hopefully the PFS curves will continue to separate more, and maybe even OS will develop as an advantage over time. But mostly it's just telling us that at this point in time, these IV patients, many of them can get really, really deep remissions, and deeper than what obviously has been seen before with other therapies. The CLL13 is the German frontline study for fit patients. They call it GAIA, and this is the study of VO. Well, they call it GV, so ven and obinutuzumab versus ven-R versus ven obinutuzumab and ibrutinib for up to 3 years, and then compared against chemoimmunotherapy, which was somewhat investigators' choice between FCR and BR. And so this is the data that we need to tell us whether we could be extrapolating Ven-O frontline data to young fit patients, because currently we would only have that funded or available or justified in older patients. The primary endpoints, there was co-primary endpoints in the study. One is PFS, but the other is undetectable MRD level at 15 months, which is 3 months after the fixed duration therapies of Ven-R and Ven-O are finished, and 6 months obviously after the chemoimmunotherapy is finished. This is meant to be a surrogate endpoint to reflect an expected PFS and OS in the future. I think it's interesting, but unfortunately, I'm not sure our funding agencies will look at undetectability of MRD at 15 months and consider it to be a firm clinical endpoint. So it sort of remains to be seen how this data will be interpreted if we try to submit it to our own agencies in terms of funding requests. But the conclusion of the study is that the level of MRD undetectability at 15 months was significantly better with Ven-O compared to chemoimmunotherapy, but not actually significantly better with Ven-R compared to chemoimmunotherapy. And the improvement from adding the ibrutinib actually didn't provide a lot more over the Ven-O. Also, there was more toxicity in the GI-VE, so the ibrutinib, ven, and obinutuzumab arm had more infectious problems, and they actually had obviously atrial fibrillation and bleeding problems that are related to the ibrutinib, and higher rate of fatal AEs compared to Ven-O or RV or chemoimmunotherapy, such that, in my opinion, the best of these therapies seems to be the Ven-O, which they call GVE. And I think that this is very encouraging data, because we didn't really have data to support giving Ven-O to young fit patients, but I think we should be doing that, at least having it as an option. And hopefully with time that will become available for our patients. The relapse refractory data, again, is just updated data. It doesn't really have anything new or super interesting. This is an update of the ASCEND study, which was the comparative study of acalabrutinib versus investigator choice of idelalisib plus rituximab or bendamustine plus rituximab. And this is a longer follow-up compared to I think it was Lancet Oncology initial publication. This shows that the PFS continues to favor the acalabrutinib really quite markedly. I don't think anybody is super surprised by that. The adverse events that are noted are relatively few with acalabrutinib in terms of grade 3 events, with the only one notable being pneumonia. And as mentioned, infections is the biggest issue with BTK inhibitors. A lot of it related to the patients being treated as opposed to even the drug effect, but obviously there is some immune suppression. We know that Idela-R is not that easy to tolerate, and it has a lot more AE problems. So they just concluded that Acala continues to beat both a novel agent regimen of idelalisib plus rituximab or a chemoimmunotherapy comparator. And then the Elevate-RR study was presented in the summer at the EHA and ASCO meetings. And I think this was the most interesting presentation of those meetings. And this was a kind of update of that, although it didn't really give us a lot of update. So this is the comparison of acalabrutinib versus ibrutinib. As a reminder, this is a non-blinded study, and they selected a sort of high-risk patient population because the primary endpoint was non-inferiority of PFS, and they obviously wanted to kind of reach their goal quickly. So they chose only patients with deletion 17p or deletion 11q. And the patients were fairly young for a relapsed CLL population with a median age of 66. The study favored, the outcomes favored acalabrutinib in terms of reduced adverse events compared to ibrutinib. And the median follow-up at the time that here is 40 months of follow-up. The major AEs that were less frequent with acalabrutinib are the ones that we worry about, the AFib and hypertension, but they also had, but the patients with acalabrutinib had more headache. I'm not sure that anybody cares that much about that. Sorry, this is the AEs of interest, the rates of AFib being almost half with acalabrutinib compared to ibrutinib, hypertension being less than half with acalabrutinib compared to ibrutinib, and bleeding being less, although not as notable. As you can see by these numbers, it looks like these events are probably all drug-related, and though less frequent with acalabrutinib, they are not gone. Bleeding particularly being an event that is still fairly frequent with acalabrutinib, but just quite a bit less frequent than with ibrutinib. Treatment discontinuations on the study were more common for side effects with ibrutinib. That's not surprising when we're reporting less of these bothersome side effects. And then there were 3 ventricular dysrhythmias and 1 sudden cardiac death on the ibrutinib arm. And that's obviously the AE that I think we're most worried about and that most influences our decision to favor the second generation BTK inhibitors over ibrutinib now for cardiovascular safety. And that was the presentations from ASH 2021.